I'm going to talk about things that I know are happening now that I think will expand in the future. So, documentation by physicians will become more ambient and automatic. There are some systems now, like the Nuance DAX system, um, where you have microphones in the examining room, and as you're interviewing the patient, it's recording everything you say. And not only does it record what you say, but it organizes it into a clinical note, giving you a differential diagnosis and maybe recommending diagnostic strategies, which I think is going to be the future. I mean, it's here now. I think it's going to get better and more influential, and that'll do a few things. It'll make the doctor's life a lot easier. It'll decrease burnout. It will increase the quality of the notes that the doctors take. So, a an aside that the patient might make, which might be ignored by the physician because he's concentrating on the patient's chest pain or their horrible infection, will get picked up and entered into the note and entered into the differential diagnosis. So, I think that's going to be a very big deal. Clinical reasoning, like clinical decision support, which exists now, I think will be not only um, uh, everywhere in doctors' offices, but will probably be mandatory because it will no longer be acceptable that there was um, information available to the doctor that he or she did not use when he was treating the patient. So, the other day I was seeing a patient and they had a 2.5 month history of shortness of breath and coughing, and they had blood in their sputum. And I said, well, this could be tuberculosis, it could be a fungal infection. Uh, and I just ran it through one of the clinical decision support things, and they suggested, had you thought about lupus or infectious endocarditis? And I said, that wasn't top of my list, but it's something I looked into. And it turned out that in this young woman, it was actually lupus. So I think that kind of help for a physician is going to be ubiquitous in the future, and I suspect mandatory. And finally, patient communication. Um, Now, when a patient comes in, you say it's a newly diagnosed diabetic, you give them kind of a standard uh, piece of patient information to take home. This is what your disease is about. This is how you treat it. This is lifestyle changes you should make. Uh, but it's a very generic thing. Not only is it generic, but it's written in English for people who have a high health literacy and reading literacy. Now, right now, you can put that into your AI and say, well, here's the patient. He's a 60-year-old Hispanic man with low health literacy and like a fifth grade reading level. Can you write me a note that uses uh, that accommodates his language and reading levels? Not only that, but um, tells him about the medications that I specifically recommended for him. So that exists now, and I think it's going to be ubiquitous in the next 10 years. I agree. And I don't think it ever should, because then physicians would be not only out of work, but it would really uh, interfere with the therapeutic relationship between the doctor and the patient. When I see a patient, uh, anything I give them that comes from the AI is clearly marked. This is produced by the AI and reviewed by the doctor. If as with that woman we discussed before with the cough, I said to her, you have these symptoms, and ordinarily the top three diagnoses would be, tuberculosis or cancer or something like that. However, in order to make sure I'm not missing anything, I ran it through the AI, and they recommended or they suggested these other diagnoses, and I'd like to do some tests to see if that's correct. And the patient was happy with that. It suggested that I was not only cared about them, but I was being very thorough, and they understood where the information was coming from. That it came from the computer, and it was a suggestion to me, not a dictate from a machine. Well, I think the first thing is it has to be relevant to, um, let's say, you're working in a hospital and it's a medical ward. Is this new AI going to do something that is measurable and that is safe and that improves something, improves documentation, improves outcomes, uh, improves, reduces the stress associated with putting all this information in? Does it add anything to it? And so uh, it has to not only accomplish something, but it has to have a workflow fit. If the AI requires, say, the doctor or the nurse to go to another screen and add in their passwords and then do a lot of this and that in order to get a result, uh, it's probably not going to get adopted. If it's integrated into the electronic health record, and it becomes something just in the background that either adds to your note or makes it easy to enter information or gives you information at the time when you're putting it in, like, oh, that medication may be contraindicated in a patient that has, your patient's diagnoses. And you're like, ah, yeah. But if but if I had to go to another screen and type in all the medications the patients had and then ask it if, this was okay, it's probably not going to get adopted because it's extra work, or at least it's perceived as extra work, and it slows down the doctors and nurses using it. So workflow fit is a big part of any new AI. From the hospital's perspective, does using this new AI earn us money? Does it decrease some cost? Are we able to see more patients in less time? Uh, and those are important to the administration, and I understand them. Not as important to me as a clinician. Uh, but is it relevant? Is it helping the patients? Is it making my life easier? Uh, and does it fit into my workflow? Those are the big issues for me. Well, I think right now, ambient scribes, the recording of the interview, um, and also the subsequent, dictation of the diagnosis and treatment plan, um, is the most helpful for me. Um, it makes things a lot faster. It's more organized, uh, and it is combined with the hospital's electronic health record. So it allows me to make eye contact with the patient, and uh, a lot of times I will dictate the diagnosis and plan for the patient to hear. This is what we're going to do. This is why we're doing it. I think that really helps the patient. Um, and after ambient scribes, I think patient communication. Um, so things that we give the patient, personalized recommendations, and this is how you take your medication. This is how you should change your diet. This is how you should exercise. All those things that you'll sometimes say during an encounter, but the patient may not always remember it or understand it as you say it. And I think these AI created communications, um, you can do it in uh, languages that you don't speak fluently. So I have some Chinese patients who actually speak English, but not really well. But I can give them notes written in Mandarin and signed off by native speakers who say, yeah, this is appropriate. It's kind of sad to think that in the recent past, we would just speak to them and you realize that they're not really getting everything I'm saying. And now I feel a little bit more confident. And it's something that they can take home, they can share with their loved ones, people that are caring for them. Like, this is what the doctor said I should be doing. So it's a big step up, I think. Well, there are two software packages that I use. There's Glass Health, GLASS, and it's an AI model that you can type in um, uh, symptoms. You can ask it. For example, I have this patient that has a new rash after getting an infection, and I'm concerned whether it's a result of the medication or a sign of a more serious infection. And it can give you differentials and explain, which is very important. Not just it could be this, this, and this, but the percentage of this happening, or this is what a rash of Stephen Johnson's syndrome looks like. um, there's also up to date has a new AI program. So not only the information vetted and up to date, but you can query like show me the articles that support a a decision to go with a particular therapy. And I think that's very important, especially in my academic center. These are things that you don't just want to tell medical students and residents, do this because I said so, but you want to provide them with, I'm saying this because there was a study with 10,000 patients who had, these symptoms, and this is how we did it. So these are things that used to take a lot of time, and now I can do it on the fly. And actually, I can just speak into my computer, and it will print out clinical studies for me. So I think that's wonderful. There is a lot of resistance. The resistance depends a lot on the age and um, computer savviness of the physicians. So I find that residents and fellows are very quick to use it. I will show them, what I'm using and how to enter it, and they're all over it. But older physicians and ones that are not tech savvy often push back. And there are some studies, done out of Stanford and other places where they said that 75% of physicians were not supportive of any kind of diagnosis or clinical diagnosis aids because they felt they didn't know how the computers came up with the information. And they also felt that it was a threat to their uh, clinical skills. They thought that if I depend on this to make decisions for me, which I think is a misapprehension of what the AI systems do, but they feel that if I do this and the computer is always making the decisions or the diagnosis, then I will become a less skilled physician. And there is, some data to support that. I know, for example, in our hospital, when I ask interns and residents to tell me what the EKG says, they will read what the computer interpretation of it was. And, I'm old enough to remember that when I was a resident, we used to carry calipers in our pockets and we would measure out all the distances on the EKG. But now it's it's uh, it's less common for a medical student or resident to actually look too deeply into the EKG, and they just read what the computer tells them to. So I suppose that has eroded that clinical skill. Um, I'm unsure of the data on the accuracy of them, but I suspect that the accuracy may be better than an intern or residence. Well, the study showed that a majority of patients are open to the use of AI. And if you couch that in I ran your information through the AI, and this is what it said, and this is what I think of what it said. And in a lot of ways, that's not different than, um, say, a blood test. I didn't count how many red blood cells were in your blood sample. The computer did it for me, the machine, the Coulter counter. But, I have implicit trust in that machine, and I think that will be the future in AI diagnosis. The blood test shows that you have a low blood count. I see this as it's probably from um, a chronic disease or an iron deficient diet. So when the AI gives us a diagnosis or a list of possible diagnosis, I have to interpret it in light of all the totality of the patient's information and experience. I think that's imperative. Anything you do with patients, if you want to maintain their trust, you have to be completely transparent. In the pre AI era, it wasn't unusual for me to tell a patient, listen, uh, your case is very complicated. And I don't know that I'm the right one to see it. I'm going to have you see an expert in this. And that didn't diminish me. This guy's an expert in rheumatology or cardiology, and he knows more than I do. And and the patients always came back to me because they said, "Oh, he cared about me, and he made a decision that helped me out." And I think it'll be the same with AI. Regulatory, not yet, because when we vet the vendors, it has to be FDA approved. Uh, but culturally, get a lot of pushback from anyone who's forced to use a new system. Um, Doctors and nurses don't like changing their routines. They have to be very familiar with the system, and it has to work the first time. And so when we're implementing a new system, uh, you know, before the system starts, months in advance, we're telling them about it. We start training. This is why it's important. This is how it's going to save things. And then we roll it out in one clinic, and we find out where the pain points are. Oh, this takes extra input. Is there a way that we can pull data from other parts of the electronic medical records so they don't have to re-input all the same data. Other technical issues that we have are bringing data between different systems. Uh, if the data is arranged differently, you have to clean up one set of data to use it into the new system, and that requires a lot of help and cooperation from our IT people. So as I said, if we're implementing a new AI system, we have to get all the stakeholders, and that includes the clinicians, the IT people. We have to use the internal review board to review it ethically. You know, does this system use data that represents our population? We have a very mixed population. We have a lot of African Americans, a lot of Asians. And when we talk to the vendors before we bring on an AI system, we have to ask them about where's the data coming from? Is it balanced? Is enough women represented? Are enough of these ethnic groups represented? If they aren't, then we can't use it because we say, I can't use a system that's going to be wrong in 20% of our population. So there's a lot goes on before a system actually hits the board. Yes, not only we have to have the clinicians, the IT, and the ethics, but we have to have the hospital administration because they have to pay for things and they also have to reallocate resources. If we have a new AI system and we have to have two IT people working exclusively on this, then they can't do other projects for the hospital. So the hospital may have to hire more people or get temps or something. Um, so it requires everyone working together, and it's a real a new AI system isn't just a new piece of software. It's kind of like a marriage. You have different parties involved, and it's ongoing. You don't just put it into the hospital computer system and walk away. There's constant monitoring and auditing of the output. Are we having any data drift or outcome drift from the outputs of the AI system? So once it's started, you create this team, and the team is, I have teams that have been meeting for 3 years monthly to go over how is our system progressing. Um, you know, are there any updates that we have to do? Do we have to train new employees? Um, and how is it performing? So it's a real problem. It depends on how it's used. Um, the way I use it, where I have considered the patient's symptoms and data, and I come up with a diagnosis, and then I'll run it through the AI system, all the same data, and see how did I do? What things didn't I consider? And a lot of times you'll learn things. And so, from that perspective, I think it increases your skills. However, like in the EKG diagnosis thing, if you just accept whatever the computer tells you, then yeah, you'll never develop any of those skills. And I suspect that will be an ongoing problem and one that we haven't created a culture around. We don't want doctors that use the AI as a like a diagnosis vending machine. You put in a quarter and you get the diagnosis.